Welcome to the Integration Session podcast, where we explore the science, stories, and future of psychedelics. I'm Dr. Elena Koning, and today I'm thrilled to welcome Dr. Jérémie Richard, a clinical psychologist, assistant professor at the University of Ottawa, and director of the Clinical and Applied Psychedelic Science Lab. In this episode, we trace Jérémie's remarkable journey into psychedelic science, including his time as a Banting postdoctoral fellow at Johns Hopkins School of Medicine. We compare the evolving regulatory landscapes in Canada and the US, how they shape access to psychedelic treatments and research progress, and we also explore new frontiers in thinking about psychiatric disorders that challenge traditional definitions in the DSM. Finally, we attempt to answer the big picture question, what will modern psychotherapy look like 20 years from now? And where, if anywhere, do psychedelics fit into that vision? Let's get into it. Hello, Jérémie, and welcome to the Integration Session podcast. Thanks so much for being here.
Yeah, thanks for having me.
Of course. How are things going with your relatively new position at Ottawa U?
Yeah, things are going well. It's very busy starting up a new faculty position. It's a lot of getting the right footing, figuring out what you're going to be doing at the university. On the research side, but also I'm teaching at the graduate level. And so it's figuring out all the administrative things as to like, how does teaching work at the university? And then which committees am I joining? And so it's not just transferring to a new institution and kind of taking my research here. There's a lot more to it than, just learning how the university works and who are the students here and what is their knowledge base when it comes to psychology as a whole and other domains. So lots of things to get used to, but I'm very happy to be here. I actually really love the campus life at University of Ottawa because it's a bilingual university. And so I grew up and I went to school in Quebec and went to English schools there. But I did find there was a lot more separation between kind of the Anglophone versus the Francophone sides. But here it's every day I'm speaking French and English. And yeah, I really enjoy that because it brings out a bit more of like what it is to me to be Canadian and like speaking both languages every day and learning how to talk psychedelics in French, which isn't what I'm usually used to. So like psilocybin and whatever else,
Right.
It's similar words, but it's just a different way of going about it. So
Yeah,
no,
are
I'm
a lot of
enjoying
the
it.
words completely different, or are they mostly similar?
It's mostly similar. So I've learned. So you pretty much just say it the same way in French, luckily. But when it gets more complex, let's say I'm talking neuroscience, let's say I'm talking clinical trial design, there's a lot of specific language that I have to be like, I've never used this word in French before. So then I have to like translate everything in my head. And then once I've found the words, then it's easy going.
Yeah.
But there is kind of that curve that I'm like realizing how much of my education has been in English and how much that informs the research I do. But I really want to do more in French, so I'm kind of forcing that learning
Yeah.
at first to be able to, communicate this type of research that I'm doing in both languages.
Yeah, no, that's really impressive. And I like that you mentioned like the English French, sort of like the duality of that, and your career beginning in Quebec. And I'd love to talk a bit more about that journey for you. So I know
Sure.
that you have some experience also in the US psychedelic landscape, and we'll get to
Mhm.
that a bit as well. But could you talk a little bit more about your journey into clinical psychology, and how you sort of evolved into this field and how you came to be in this position that you are in today?
Yeah, sure. So, I'll start after high school because or else it's going to get a really long life
Yeah,
story.
yeah.
But in Quebec, we have a program between high school and university called CEGEP. And we have one less year of high school compared to, let's say, Ontario. And so we have those 2 years. And so our university is only supposed to be 3 years because of that. So we do kind of that extra year of high school in CEGEP and that first year of university in CEGEP. And I studied liberal arts in CEGEP, which is a general kind of humanities program, social sciences program, because I didn't really know what I wanted to do come university at that point. I had heard from various family members to be like, especially my uncle, that was a big influence on my life, was like, oh, you should become a psychiatrist. You're really good at listening and da da da. And I was like, okay, maybe. But then I was also very interested in law, which was quite an area that I was like, oh, maybe that would be interesting to pursue. I was always quite good at memorizing things, so I'm like, maybe I could use that as a strength. But then in Cégep, I had my first psychology course, which I think was a sports psychology course, which really got me interested in like, oh, the human mind and performance and motivation and flourishing and flow states. I was like, this is incredible. And then that led to me taking more and more classes up until the point that I was like, hey, I might actually want to pursue a bachelor's degree in that and further my education in psychology. And I had also gone to, I went to McGill for my university, and I had gone to a pre-admissions meeting for law school. And I was there. I was 18 years old. And then everyone else that was there was like mid-20s, early 30s, like going to law school. And I'm like, I feel like I'm not at this level. So it's not a bad idea for me to actually do an undergrad if I am to choose to go into law and then go into law afterwards. But then once I started studying psychology, that was kind of it for me. I was like, nope, I'm staying here. This really feels like my home. And so I did a bachelor's of arts in psychology with a specialization in behavioral sciences. I still did a minor in politics, law, and society because there was always that piece that I was always very interested in, the interaction of politics and sociology on human beings and how we're all living within these systems and these cultures. And I guess you could see some of that in my later work when I'm commenting, especially on psychedelic related policies and social contexts and how that all relates to accessibility. So I guess it came out to be pretty useful in the end of things, like learning the Canadian Charter and things like that, human rights, was very useful. But I completed my bachelor's degree. I always thought bachelor's degrees were 4 years because I was the first one in my family to go to university, and all the information I had was about like US movies. So it was all like 4-year universities. And by the time I got into my third year, I'm like, wait, I'm supposed to graduate now? Oh no. And so there was kind of a rush there to try to figure out what to do. I didn't know I needed to do honors to get into grad school. And so at that point, I was like, oh no, I better do a bit of research. And then I actually joined a lab where I had my first experiences in research, which were in psychosocial oncology and in the psychosocial consequences of infertility, especially amongst those that go through cancer therapies, let's say younger men with testicular cancer, that perhaps that results in them having to go through various protocols that might impact their fertility. And so how does that impact their quality of life and well-being? And so there was a lot of health psychology overlap in my work. And I ended up doing a undergraduate specialization and writing a paper on that topic. And I had a weird transition there from the supervisor I had at the time. I was also very much interested in learning about addiction. And I got set up with the person who became my master's and PhD supervisor in counseling psychology at McGill, Dr. Jeffrey Derevensky, who was studying gambling behaviors, but also substance use behaviors in youth and young adults. And that was really interesting to me because it had also a developmental lens. So understanding various social and psychological factors that can relate to the development of these behaviors, which can then become problematic later in life. And so I did a lot of research in that domain throughout my master's and then my PhD. We're on the integration podcast here. So psychedelics to me didn't really come up until much later down the line, where I was drawing all these connections between my previous experiences, let's say in psychosocial oncology and treatment of addiction. And I think the first paper I read on psychedelics was the work of Dr. Matthew Johnson and Roland Griffiths, which was a pilot study of smoking cessation with psilocybin. And I had also started working with folks with substance use disorders at that time. And I was like, what is this psilocybin treatment that people, that study after the year follow-up, 10 out of 15 had completely stopped smoking? And I was like, what is going on here? And that really led to me studying psychedelics more. And in my PhD, I was also on doctoral residencies. And so I did a residency in the mood and anxiety disorders program. And people began, my patients at the time were talking to me about like ketamine and psilocybin and these various things. And I was like, okay, there's like interest coming from my patients here about this. And I'd be curious to learn more. Like I'd only heard about those things at a distance and through the research I had read. And so I was like, maybe this would be something interesting for me to study. Because I always wanted to study psychotherapy, but the pharmacology was also an interesting piece because then I get to tie in more of the biological sciences and neuroscience. And so to me, psychedelics all really brought things together. So I'll pause before going on to my postdoc in the States.
Yeah.
But yeah,
No.
that's a bit of a, a tour there.
Yeah, that's super interesting. It almost feels like you ending up in the field of psychedelics is inevitable considering your background in all these different areas, even law, that is obviously such a prominent aspect of the field today,
Hmm.
and your clinical psychology interests. It makes sense why you ended up here, I guess is what I'm saying. But yeah, please go on with your
No,
postdoc.
well, I
I know the dream
remember.
is in there.
Yeah, when I first started my PhD, I wanted to do a clinical trial for my thesis, as I think a lot of students want to do. They're like, oh, I want to do a clinical trial. And then Dr. Derevensky was like, are you sure? Do you ever want to graduate?
Yeah, you want
And
to
I was
be
like, I actually took that advice seriously. And I was like, okay, maybe I do that later. And then I was
yeah.
like, when is later? And then I'm like, I mean, I kind of came at a crossroads too at the end of my PhD in clinical psychology, as I think a lot of students do. Because if you have the right to practice as a psychologist, that is a professional avenue that you could take that branches you out of academia, and you could go and work in a hospital or you could go and work in private practice. And I was seriously contemplating that for quite some time because research can take a lot out of you, especially over those years in graduate school where you have to do both, write your thesis and also do clinical work. And I really enjoyed the clinical work because I felt I was having a human impact on a day-to-day level in meeting with clients or patients. And it's that immediate gratification of psychotherapy in a way when you're helping someone and you're seeing their progress. It's not the same as research that might take months, if not years, for you to see the fruits of your labor, so to speak, right? And so I was seriously considering that. But I jumped to research back again when I was like, maybe if I could do research in clinical work, then I'd be happy to do research. And that's, something that led to me looking at psychedelics because I really wanted to do psychotherapy research, but who's doing psychotherapy research? Who's funding this type of research? There's not as much money in psychotherapy research, unfortunately, if you want to get money to run this type of research and develop behavioral interventions. It's not as prominent as pharmacology research, where you could apply for grants and do all this work. You can do that with behavioral research, but it's much more challenging from my lens at the time. And so to me, kind of bridging that gap and being like, maybe we could do both. And the place that I saw that as being most prominent was also with psychedelics. And that's not to speak about, my own personal spiritual and contemplative practices and what I'd been reading and the various connections I was seeing with psychedelic experiences. Especially during the COVID years on lockdown, I was reading philosophy and spirituality and looking into all these things and finding those parallels and from a non-academic perspective. And so seeing a way to bridge personal life, professional life, research, clinical work all together was really a way of integrating all of that for me. So I
Yeah.
was really grateful when I had the opportunity to go to the States and conduct research, clinical trial research using psilocybin specifically.
Yeah, yeah. Could you talk a bit more about that and your time at Johns Hopkins?
Sure. Yeah, so it was kind of a shot in the dark, to be honest, where I said, if I am going to do a postdoc, what would I really want to do? And I landed on doing this type of work, specifically interested in doing this work at Hopkins because the Center for Psychedelics and Consciousness Research had been doing most of this work that I had been reading at the time. I mean, there are other institutions doing this work, some in California. That's a bit far for me. Being on the East Coast, I kind of wanted to stay on the East Coast. There was also NYU. They had great research looking at alcohol use disorder. Also some cancer trials coming out of NYU. But yeah, Hopkins was kind of the number one pick. So I cold emailed various members at the center. I did that once, I got no response. I was like, okay, I'm going to try again. I tried again and I did get a response. And the response that I got was, if you apply for a postdoctoral fellowship, and we'll support you in doing that, but if you apply and you get money, you could come down and do research. And so at the time in Canada, there was this fellowship called the Banting Postdoctoral Fellowship, which really looked at developing synergies across institutions, especially internationally. And so I applied for that Banting Fellowship with Dr. Albert Garcia Romeo at Johns Hopkins. And I ended up getting that fellowship. And I think I got the news around February of 2023. And then I had to make up my mind for September of whether I was going to do that in the midst of my doctoral residency that was still going on until August. So I had to make that decision. Am I going to go to the States and do this? And obviously I made that choice. And so I moved to the States from 2023 to middle of 2025 to do that work. And it was really an incredible experience going to a center like this with so much ongoing research. I got to primarily be involved with clinical trials in the domain of addiction. So I got to work on trials looking at psilocybin for smoking cessation and tobacco smoking, also for cannabis use disorder. And when I was there were other ongoing trials, including alcohol use disorder, comorbid with depression, an opioid use disorder trial started up. So there's a lot of addiction work that was happening that I got to be involved with. And one that was kind of out of the blue that I was not expecting, Dr. Garcia Romeo was looking at the potential for psilocybin in the treatment of Lyme disease, post-treatment Lyme disease, which has a lot of psychological but also physical symptoms, chronic pain, fatigue, depression, poor quality of life. Because when people contract Lyme disease, you get treated immediately if you're able to catch it with antibiotics. But if that doesn't work, there's not really another treatment that's there. And so this was an open label study looking at whether psilocybin can help. There were hypotheses as to maybe it has anti-inflammation effects on the body or the brain. But the results that we got from that study is really surprising. Those data should be published this year, hopefully. But yeah, there's some things happening there that we don't really understand the mechanisms, whether it's the psilocybin, whether it's the therapy or therapeutic alliance that comes with that treatment, whether it's the mystical experiences that arise from that. I mean, for such a physical ailment, it would be surprising to me that mystical experience actually predicts well-being afterwards, but we'll see what comes out of it. But to me, that really bridges that mind-body connection. That's like what's happening here that we don't really understand, that psychedelics is allowing us to investigate much further, which I find is truly fascinating.
Yeah, the transdiagnostic aspects are truly wild. I mean, I
Yeah.
would think that Lyme disease would be something, but I'm surprised every day with new indications that are being investigated in the field. And yeah, so I mean, Johns Hopkins is obviously a very leading institution in psychedelic research. So how was it being at the center of that? Like, what was that experience like? Was it exciting? What sort of did the institution feel like, I guess, being a part of it?
Well, first, it's much bigger than what I was used to. I mean, in my lab, because I believe my supervisors during my PhD, last student, it was me and a colleague doing her PhD as well. And then she graduated, and then I was alone doing my PhD because it was kind of end of career, although Dr. Daravinsky is still working to this day. It was a thing where I was myself, my supervisor, maybe some collaborators I was working with, which resonated very well for me, but it was much smaller versus when I got to Hopkins. I believe there's maybe 8 to 10 faculty that are a part of the center. And then each one of those faculty have 1 to 2 postdocs. And then they also have teams of research program coordinators that are post-undergraduate students helping coordinate the various clinical trials that are happening. And there's study therapists, there's psychometricians. So it's a team of more than 30 people working on various clinical trials. And the beautiful thing about that was that I have now, this network of colleagues. I would consider them my friends too, especially among the postdocs, that we just had such a great connection amongst each other. So we get to work on research, but it also developed relationships over those years that I was there, which is really wonderful. But then to have like-minded people What sticks out to me most, yes, of course, working on clinical trials, but oftentimes it was our Wednesdays. We would all go to lunch together at the cafeteria and continue having conversation following our morning meetings at that, cafeteria table. And so many ideas came out of those lunchtime conversations. I actually wrote a paper with a colleague, Michael Levine, that pretty much arose out of those lunchtime conversations. So it was really that in-person collaboration, conversation that leads to a lot of ideas coming out. And yes, then you do have to go and do the work. But that's very inspiring to feel like we're all working towards the same thing together. And to have the resources to be able to do that. The most marking thing for me there was that I don't know how many clinical trials are going on at the same time, to be honest. I mean, there's definitely more than 5 or 6 or 7 happening at the center. And so a lot of clinical material, a lot of different investigations and methodologies. So I learned so much about clinical trial design while being there, not only designing protocols or applying for funding to do this type of work, but then also how does an early stage clinical trial work? How does a middle stage clinical trial work? How about towards the end, data collection, managing databases, analyzing findings, right? So as these trials take multiple years, to be able in 2 years or a bit more than a year and a half to have experience at each stage of the clinical trial process was hugely rewarding. And I'm extremely lucky to have had that experience in so little time.
Yeah, that sounds incredible. I'm sure you're thankful that you did end up taking the leap to go do that. That's a bit of sort of, I guess, like the micro environment being there in the States, but what about sort of more macro? Like I know you published on the regulatory differences between Canada and the US, so I would love for you to talk a little bit about that. Particularly, what does that look like in terms of access and facilitating research programs? What are maybe some advantages or challenges that you've encountered in each research environment, and just how do those sort of contrast?
Well, to my knowledge, in the States, in order to be able to do psychedelic research, there are various approvals that have to be put in place to get your center or clinic or hospital approved, because psilocybin or other compounds are Schedule 1. And so you do need a DEA license. You do have to get FDA approvals. So those are 2 different organizations in the States that have to give you the go-ahead to do the work. But then you need to have institutional review board approval as well to do the work. So there's a lot of administrative and institutional overhead that goes into doing it. Luckily, Hopkins already had all those previous DEA, FDA approvals to do research. You still have to apply for an investigational new drug or IND application if you want to test, let's say, a psychedelic for a new indication. But a lot of the groundwork had already been laid, right? There's a pharmacy there, there's storage for the substance, it's all safe, it's all controlled, all those things are there. So it'd be different if you're trying to start a new psychedelic research center in the States. There's a lot of hoops that you have to go through to actually get that established. But once that's there, then you could do clinical trial research. Outside of clinical trial research, access to psychedelics is extremely limited in the States. So they do have a expanded access program that they have for investigational new drugs to be used for various conditions, but it's not very much being used for psychedelics. The only people who got approval, to my knowledge, to use psychedelics in that way was MAPS at the time, or the Multidisciplinary Association for Psychedelics Science or Studies, where they got approval to give MDMA to 50 people for PTSD through this alternative program, but that was it. Versus the Canadian landscape is we do have clinical trial research as well at various institutions. And over the last 3 to 5 years, I'm always surprised to see more institutions doing this type of work. But we do have the equivalent to their expanded access program called the Special Access Program in Canada. And that has allowed a lot more people to gain access to psilocybin and MDMA without going through the clinical trial pathway. it is labor intensive to apply. Like a doctor does have to write a recommendation to Health Canada to gain approval to use psilocybin or MDMA for a specific condition. But once all those things go through, then you can have access to it. And there are hundreds of people in Canada that have received access to psychedelics outside of clinical trials. And so Canada is much more open when it comes to alternative pathways. Surprisingly, at the funding level, I also think, even though the States has a lot more money to go into research, to my knowledge, I think Canadian government is giving much more money, especially through Canadian Institutes of Health Research, to psychedelic research. Like just this year, I've seen multiple $1 million grants being given to different institutions. I think yesterday I saw a new one for some researchers in Toronto to look at psilocybin for depression while maintaining SSRIs. There's also an MDMA study for chronic pain that's going to be happening. So I'm seeing a lot of money going into this, whereas in the States, I'm trying to keep my eyes open and look around, but I'm not seeing as much government-funded research into psychedelics. And I might be wrong on this, because of course there's so much going around that I can't see everything. But it tends to be more philanthropic funding in the States. So non-governmental organizations or individuals giving money to do research in psychedelics, which is how the Center for Psychedelics and Consciousness Research got started, through donations to Johns Hopkins to do this type of work, right?
Yeah,
So different landscape for sure.
Yeah, and would you say that there's maybe more industry interest in the US compared to Canada, or would you say that's comparable?
So that's a great point. So the US does have a lot of industry doing this work. For example, Compass Pathways and their studies looking at psilocybin, or their Comp 360, synthetic psilocybin for depression and now PTSD. So there is a lot of money on that side, yes. Kind of patenting treatment approaches or compounds to be able to do that type of work. You do see that a lot more in the States. Not to say that it's not happening in Canada, but what I'm seeing on the industry side in Canada, those are there, but it seems to be people more working on botanicals and synthetic botanicals to be able to provide, let's say, psilocybin in this case, to researchers to do that type of work. So it's a different model, perhaps, of distribution of profit, if you will. It's still here, but it's different. And so you're now seeing various trends in where are researchers getting their psilocybin, for example. There tends to be one bigger player, and that player is Canadian. So that's interesting to see.
Yeah, definitely. Yeah, thanks for walking me through those differences. I know that you've published on this, and I just think it's so interesting for people to hear about. And in terms of your other published or unpublished work, this question's kind of fun, but I wanted to include it. What would you consider to be your most impactful work so far?
Impactful. How do I measure impact?
I'll leave that up to you.
Okay.
Maybe personally impactful or
Okay. Yeah,
some...
that one I could do.
Yeah.
Yeah, personally impactful. Yeah, there are several to come to mind. I mean, there's one paper I briefly mentioned earlier that I worked on with Michael Levine when I was at Hopkins, which was about defining the role of well, what is psychological support when people are claiming they're doing this so-called psychological support in psychedelic therapy. What is that? Is it psychotherapy? Is it something else? And so we had a fun kind of intellectual exercise that's trying to develop or apply a framework to understand that phenomenon, and what observable behaviors are we able to look at and say that's psychotherapy versus that psychological support, if that's even possible. And so that was more of a, let's say, of a synthesis paper, a theoretical paper, if you will, where we are more conceptual, where we tried to provide the field with like some sort of framework that hopefully could be useful in the future. And so we worked on that from, I think, 2024 and was published early 2025. But personally impactful for me, so I have a deep interest in the history of psychology and psychotherapy as a whole. And I'm very curious about psychoanalysis and how the field of psychotherapy started with psychoanalysis and moved into more cognitive approaches, behavioral approaches, humanistic approaches, and now kind of third wave approaches to psychotherapy, such as ACT or acceptance commitment therapy, unified protocols, dialectical behavioral therapy, et cetera. But I was trying to kind of locate myself as like, where am I in this, history of psychology, and if you want to draw it further, philosophy of mind. And so I ended up writing a book chapter about the history of psychoanalysis in Quebec and understanding kind of the roots of psychotherapy and where that came from, primarily from Europe and, of course, Sigmund Freud and colleagues. But then also like what happened during World War II. Where did these people go when it comes to the States and Canada, and who were these influential voices that brought psychoanalysis, and at that time that was all of psychotherapy, right, to the States and Canada. And I was kind of drawing a genealogy of psychotherapy to try to see where are we now. And I guess that maybe was a personal quest of mine too, of being like, where am I falling within the grand scheme of psychotherapy and psychology as a whole. And I realized that, psychology and psychotherapy as a field, it's not very old. It's early 1900s, right? So we're 125 years in. And so if you go back 3-4 generations, it's there, right? So you're able to literally trace it back to some founders and see how those things influenced where psychotherapy is now. And that was also for me to understand why certain institutions teach more CBT versus others are more psychodynamic. In Quebec, you see that a lot with McGill being more in the cognitive behavioral therapy side of things, and other institutions like Université de Montréal or University of Montreal, you do get a lot more humanistic, psychoanalytical, psychodynamic training. So there's also like a language piece, a geography piece, a society piece, a cultural piece. And so to me, that was really important to kind of locate myself within all of that, and then to look towards the future, right? And where does that bring us? And, and now you bring in, after the fact, bringing in psychedelics within all of that, bringing it back to Humphrey Osmond and Saskatchewan, amongst others. I mean, of course, psychedelics have hundreds of years of indigenous practices as well. But from a Western biomedical lens, starting in Europe and in Canada and Saskatchewan, that type of work that was happening, and where we're at now, that adds another piece to that whole history, right? Like, what was the role of psychedelics and how psychotherapy has evolved over time, right? And now we have folks like Stephen Hayes, the co-developer of ACT, talking about how his psychedelic experiences in the 70s influenced him developing that approach and how it would work very well with psychedelics. That was maybe last week or 2 weeks ago. So we're seeing all those different aspects being connected, and it's like, it's not so separate here. All this history is very muddy. It's very hidden. There's a psychedelic underground that's not really talked about. So to me, that piece was significant, and I'm still to this day kind of drawing in those historical ties in that lineage. That was actually published in a book in Quebec about the history of psychoanalysis in Quebec. So that's to me, that was one of the most meaningful things I did, and in addition to the people I collaborated with to work on that very impactful project.
Yeah, that sounds super interesting, and it is truly incredible that some of these key events that we mentioned in the timeline of Western psychedelic research aren't actually that long ago, and we're still sort of unpacking those and looking into these studies still, and it's an interesting time for sure in the history of it. So I guess, situating yourself there in that sort of landscape sort of, I guess, allowed you to identify where you want to go moving forward, like you said. So could you talk a little bit about that? What are your current investigations, current projects, and interests in terms of your role as director of the psychedelic lab at University of Ottawa?
There are a few projects that I have in mind. I mean, many of which are collaborations. But my personal interest in research is anything at the intersection of understanding the transdiagnostic potential of psychedelics, psychedelic assisted therapy specifically, and seeing how, we talked about Lyme disease, other folks look at research in cluster headache and all these other physical ailments. But if we do focus more on the psychiatry side, as per, let's say, the DSM, or other classification manuals or nosologies for understanding mental health, I'm being pulled more and more towards a dimensional understanding of mental health, which is seeing more of these various symptom patterns on a spectrum, more so than distinct categories with thresholds that were decided upon based on committees and of course, science as well. But I am thinking a lot more about the potential for psychedelics to impact mechanisms that are underlying various manifestations of mental health, may it be depression, anxiety, post-traumatic stress disorder, obsessive compulsive disorder, substance use disorders, or behavioral addictions like gambling disorder. There's something common across all of those. And what is that thing? And psychedelics seem to be affecting that on a certain level because we're seeing transdiagnostic potential. And so I think a lot of my work is going into trying to understand those underlying mechanisms, that perhaps it is the psychedelics that access this, or perhaps it's the synergy of psychedelics and psychotherapy together, which is my hypothesis right now, is that it's likely a synergy of both, which is extremely difficult to break apart empirically in research. And so my hope is that I'm able to contribute to that developing area of research, specifically some interesting dimensional nosologies such as the high top or the hierarchical taxonomy of psychopathology is fascinating to me. I recently saw last week that various folks working on the DSM are thinking about coming out with a new version that actually looks at disorders, yes, as categories, but more and more in that dimensional view. So I think that's where psychiatry is going as a whole. And there's a dimensional model for personality disorders. Other disorders are going to be looked at that way. They're trying to identify these transdiagnostic mechanisms. So, maybe in 5 to 10 years, we see the DSM-6, and that features a lot of those changes. And I think that's something that the field needs, because comorbidity is so common, right? The fact that there's more than most patients or clients present with more than one disorder. So what does that mean, right? And how can psychedelics have potential across both, right? And so a lot more psychedelic research too, looking at comorbidity. And so some folks at Johns Hopkins right now, the study led by Fred Barrett, are looking at alcohol use disorder and depression together, and how psilocybin with motivational interviewing and cognitive behavioral therapy could be helpful for those individuals. And so that's combining the work that's been done with depression, but also alcohol use disorder together, right? And why not combine it? I mean, a lot of people with an alcohol use disorder also have depressive symptoms, right? So to look for this group of people that only have an AUD is not the rule. And so looking at these things transdiagnostically is very interesting, and identifying those underlying mechanisms. And finally, I think also understanding the role of psychotherapy a bit better in the context of psychedelic-assisted psychotherapy. And so what is the contribution of that? And that's challenging because it requires clinical trials with multiple treatment arms, right? Like the work that's going on right now at the Canadian Network for psilocybin-assisted or psychedelic-assisted cancer therapy, that's what they're doing, right? We're trying to figure out if we add psilocybin with different types of psychosocial, behavioral, psychotherapeutic interventions, is there a differential impact comparing one psychotherapy to another, right? And that's work that I think needs to be done. We've compared psychedelics to placebo, high dose to low dose to moderate dose, but no one's really looked at differential behavioral interventions. So I think that needs to be done. So I think that's where the field is going.
Yeah, I completely agree with you. I mean, my research in the field of psychedelics and eating disorders were sort of along these same lines as well, thinking about eating disorders as transdiagnostic or dimensional illnesses with all the comorbidities that we see with them, and that not only does your prevalence of one disorder increase your chance of having another, but also the severity of your illness and the resistance to treatment. These are all things that are impacted by having more than one illness. So I completely agree with your interest there and the importance of psychotherapy in really taking advantage of any neurobiological alterations that can happen with psychedelics. I think there's so much potential there. So yeah, I look forward to seeing that work sort of
Mm,
evolve over the coming years. And yeah, we're nearing the end of the conversation, so I really
okay.
wanted to get this question in. We're talking about,
Mhm.
your vision for how psychiatry will evolve, and I'd love to know how you think that modern psychotherapy practices, how those could look like in
Mm.
25 years or so, and how might psychedelics be involved in that picture, if at all.
Mhm. That's a great question. It's hard for me to predict. Also, not being a psychiatrist, I don't have much influence in the direction psychiatry goes. As a psychologist, I'm more following along and trying to bring in my perspective, which is different from the perspective of a psychiatrist, I would think. Um, I think the if we're talking at the intersection of psychotherapy and psychedelics, I think Europe, especially in Switzerland, the Swiss model to integrating psychedelics into care is very interesting. And I do believe that that's likely where a place like Canada might be going. And the way their system works right now is that, let's say, patients are undergoing care in a hospital setting and they receive the a typical protocol for either pharmacology or psychotherapy, right? So if they're facing depression, let's say, they might be placed on SSRI or other pharmacological treatment for depression, right? If that's their choice. And then over the course of 6 to 8 weeks, we see how that goes. You titrate the medication up and down to try to find the optimal dose. Maybe you switch medications. That's the work of a psychiatrist, right? And if a person chooses they would like to undergo psychotherapy, let's say for depression, once again, then that would be something that's offered, right? Perhaps a cognitive behavioral therapy, behavioral activation, something of the sort. Maybe if there's emotion regulation difficulties, some dialectical behavioral therapy or acceptance commitment therapy, etc. If they are then non-responsive to that treatment, I think that is where psychedelics could come in. May it be ketamine, may it be psilocybin, may it be some other novel compound that emerges 25 years from now, to see if that could result in some type of change within that general psychotherapeutic process. And so there's some folks in Germany, I think Max Wolf is one of the researchers on this project. Might be wrong, so I apologize if I am. But seeing psychedelics as a tool in psychotherapy, that's how I think about it, where there are key moments in my work with clients or patients where I'm like, a psychedelic could be useful here for XYZ reason, based on my case conceptualization, right? Like if someone is, in the case of depression, very low energy, very lethargic, they can't really concentrate, they can't really focus on the treatment, there's not a lot of behavioral activation, their body, the energy levels aren't there, then perhaps an earlier, for example, ketamine dose might be useful to allow them to maybe experience some relief from that low mood in a way that doesn't take 6 weeks like a SSRI might, right? It's kind of day of, the next day they're more energized, they're more present. Okay, now maybe there's more ketamine, maybe we go back into the psychotherapy, we could work on this, see if we're able to maintain these positive effects. And so I could see a model where it's maybe used earlier on for that type of case that needs to be engaged in treatment a bit more, right? But there might be a case where someone is stuck in treatment for various reasons, again, based on your case conceptualization. Maybe there's repetitive patterns of thinking that aren't helpful, various behavioral patterns that aren't helpful, and they're really stuck and they're trying to change, but they just are struggling. Then perhaps a psilocybin or an MDMA or something like that session in the context of that psychotherapy can help them perhaps break through, right? Maybe gain some insights into that behavioral pattern, maybe have a mystical experience that changes their perspective of themselves, others in the world. Maybe there's a spiritual component to all of this that leads to behavioral change. But I see it as being integrated within a broader paradigm of psychotherapy in more severe cases, right? Maybe in private practice cases, it's more or less useful, but I think especially in hospital settings, tertiary care centers where patients can be in treatment for 6 months, 12 months, 2 years plus, something to help them. I see that as the structure is there. The rooms are there, the support is there, right? There are interdisciplinary teams already in hospitals, right? So you're able to administer that. But then the only consideration is time and cost, which I think still has to be sorted out.
Yeah, for sure. Yeah, and it sounds like you're describing sort of a more individualistic approach or a personalized approach to incorporating psychedelics, not for a population, but on an individual basis. What is their progression in psychotherapy and when would be beneficial at the individual level? It's really interesting.
Yeah, and
Yeah.
then that's not to speak about the potential in couple therapy, group
Yeah.
therapy, using these compounds. I think there's a lot of opportunities there as well. So maybe that does help address cost and more systemic factors there as well. But I think that's another direction the field is going, is moving away from individualized treatment while still keeping the treatment personalized to them, if that makes sense.
Yeah. Yeah, that makes sense. Yeah. Well, we'll have to check in again in 25 years and see if the predictions have
Yeah,
come true.
hopefully I'm still around then.
Yeah. Awesome. Well, thank you so much, Jeremy, for chatting with me. This was truly a pleasure.
Yeah, thanks for having me.
Thank you so much for tuning into this conversation with Dr. Jérémie Richard. I'd like to thank the Centre for Psychedelics, Health and Research at Queen's University and the support of our sponsors at the Ontario Brain Institute, the Canadian Biomarker Integration Network in Depression, and Providence Care Hospital. Until next time, be well and integrate wisely.